Welcome to Mid One Pager. My name is Benjamin, and today I'm going to be talking about obstructive jaundice. In this video, I'm going to cover the causes of obstructive jaundice, and this is going to include a number of different diseases. We're going to look at the things that could mimic obstructive jaundice, the Courvoisier's law, which is a high-yield law when it comes to abdominal surgery, then the Mirizzi syndrome, and then we shall generally look at some investigations we can do to identify the different causes of obstructive jaundice. We'll look at the complications of obstructive jaundice. And at the end of this video, I'm going to give some high-yield tips or high-yield key points when it comes to approaching questions or a patient with obstructive jaundice. So when you look at obstructive jaundice, this is when we have cholestasis, or we are not having the movement of bile due to a mechanical obstruction. And in some books, it is also known as surgical jaundice because most of the times the management is going to be relieving of that obstruction surgery. So just to review a bit about the anatomy. Now we have the hepatic ducts, the right and the left. They join together as they come out of the liver and form the common hepatic duct. Then the common hepatic duct is going to be joined by the cystic duct, which is coming from the gallbladder. And when they join together, they're going to give us what we call the common bile duct. And as the common bile duct goes down in the C loop of the duodenum, it is going to come down and it is going to be joined by the pancreatic duct at an ampulla, which is called the ampulla of Vater. And together, after formation of this, after the common bile duct and pancreatic duct have joined, they're going to empty into the duodenum through the sphincter of body. So, when we look at the causes of obstruction, most of these are going to be extrahepatic causes. Most of the extrahepatic causes are the ones that are going to give us the obstructive jaundice. And in 90% of the cases, they're going to be caused by gallstones. And gallstones we can have things like cholangitis, which is stones within the bile ducts. We can have an impacted stone. We can have the Mirizzi syndrome, which has types 1 to 4, and we're going to look at those. Then we can have recurrent pyogenic cholangitis. Then we can look at malignancies. Sometimes the obstruction can be due to a tumor that is growing and compressing and that. So when we have malignancies, the pancreatic head carcinoma is the most common. Remember, the pancreas is located next to the common bile duct. So a tumor within this head, the head of the pancreas right here, a tumor here can easily compress this common bile duct, cause obstruction, and then you shall end up with the obstructive jaundice. Other carcinomas include the cholangiocarcinoma. If you have a carcinoma in the common bile duct, that can result into a blockage and then you end up with a obstructive jaundice. Then others can include the biliary carcinoma. We can have gallbladder carcinoma and Prehepatic lymph nodes. These are lymph nodes that are located around there. So if you have enlargement of lymph nodes, the lymph nodes can compress on the common bile duct and then we shall have obstructive jaundice. Then we have benign strictures. The strictures can come post-operatively when we manipulate the biliary tree. It can be due to chronic pancreatitis. It can be IgG4 related cholangiopathy. It can be ischemic strictures. This can be post-radiation or post-instrumentation, like when you do the ERCP. Then we have the congenital abnormalities, which include the choledochocyst, and this one has the Todani types. And we have Caroli's disease. And then we have the parasitic infections like Ascaris lumbricoides, which are the roundworms. We can have chlorhexidine, obstructosis, which is the Chinese liver fluke, and then fasciola. And this also can cause obstruction and give the features of obstructive jaundice. Then we have some intrahepatic cholestasis, whereby we have the obstruction is up. It's not in the common bile duct. The obstruction is up within the liver, so the bile is stuck within the liver. We can have things like primary biliary cholangitis, primary sclerosing cholangitis. We can have the drug-induced liver injury, DILI. Viral hepatitis sometimes also can present with the cholestatic pattern. And then we have sepsis-associated cholestasis, as well as total parenteral nutrition cholestasis, and infiltrative. And the infiltrative conditions like sarcoidosis and lymphoma. So when you look at the Couvre's law is when we are basically it is a law that was made by this man Ludwig Couvre, and he noticed or he observed that whenever we have a person with jaundice and a gallbladder, so when you have a painless jaundice plus a palpable non-tender gallbladder, then unlikely it is due to stones. So if it's not due to stones, you want to think it is a malignant distal biliary obstruction. And most commonly, that is the pancreatic head of cancer. But as we have seen, there are other cancers around there that can cause this obstruction, so they are known. The pancreatic head of cancer is the most common. But this law is going to rely on the fact that when someone has chronic gallstones, the gallstones are going to cause irritation within the gallbladder. And because irritation, there's going to be inflammation. When there's inflammation, we shall have then fibrosis, and then the gallbladder will contract. So, if someone has now an impact, a blockage downstream, and the gallbladder is already fibrosed, it cannot expand. So that is what the law, basically, the principle behind the law or the rationale of the law is. But sometimes you can have what we call the false positives and the false negatives, or the exceptions of the Couvre's law. So when you have a double impaction, for example, if you have a stone in the normal gallbladder, if you have a stone in the gallbladder and a stone blocking cystic duct and another stone blocking the common bile duct, we're going to have a cholestasis whereby the gallbladder is going to be palpable, yes, and you're going to also have jaundice. Then also, if you have a stone that is in a normal gallbladder, remember the piece relies on the gallbladder having undergone fibrosis due to chronic chorelithiasis, or stones being there. So if that gallbladder is normal and then we have a stone lodging, it's going to expand, and then we could have a palpable non-tender gallbladder. Then when we have Mirizzi syndrome, also where the stone is located within the gallbladder but somehow compressing on the lumen of the common duct, we can have also a false positive for this, and you may think it's malignancy. Then the false negatives, if you have previous chronic cholecystitis and now you get a tumor, still you could think that it is not, because the gallbladder is not palpable, you may think it's not tumor, but actually when the tumor is there. Then also imagine someone who does not have a gallbladder, they have undergone cholecystectomy, but then after they have an obstruction, they are also known to give a false negative because the tumor is now causing obstruction, but you cannot palpate the gallbladder, so you would think that there is no tumor according to Couvre's law. And then you have cystic duct invasion, and then if the tumor is above the cystic duct, also we may think the gallbladder will not be palpable. So if you come and check and say, oh, I have no palpable gallbladder, so it is not a tumor. So we look at Mirizzi syndrome. Mirizzi syndrome is when you have a stone within the gallbladder that is compressing on the lumen of the CBD, the common bile duct, and this is going to occur when the stone is within the Hartmann's pouch. So when we have type 1, we have a stone that is in the Hartmann's pouch and is compressing the CBD, but the lumen is still patent. There's no decompression of the passage of bile. Then in type 2, we have compression of the CBD with the lumen narrowing. Then type 3 Mirizzi syndrome, we have compression causing the wall of the common bile duct to undergo necrosis. And then in type 4 is when we have ulceration into the common bile duct by that stone, leading to formation of a choledochal fistula, and most of the times this is treated by endoscopic retrograde cholangiopancreatography. So the pathophysiology is that when we have an obstruction, we are going to have an increase in the duct pressure. When you have an increase in the pressure, we have reflux of conjugated bilirubin. And when the bilirubin is not going down, it's going back up into the hepatic system and upwards. We're going to have dark urine and bile store. And the dark urine is going to be because of the lack of uropyrogen, which makes the urine that yellowish color. Then when we are not excreting this bile acid, we're going to have bile acid retention, and then bile acid is retained and into the bloodstream, you're going to have a pruritus because of its deposition of these bile salts on the skin. And also this bile acid is going to go back into the hepatocytes, and because it is of its irritative nature, we're going to have inflammation and then cirrhosis. So we can have secondary biliary cirrhosis. And then because the bile is not going down into the duodenum, we're going to have no micelle formation. And these micelles are the ones that are important in absorption of fat. Remember, fat is not water soluble. So to make it water soluble, it is absorbed by these micelles and carried within them. So we're going to have a steatorrhea because fat is not absorbed, so we shall have fatty feces. And then the fat soluble vitamins, vitamin A, D, E, and K, are going to become deficient. And then because of prolonged stasis, we can have cholangitis because the stasis is going to give way to overgrowth of organisms, and these organisms are going to get into the bloodstream, and then we have a sepsis and the features of ascending cholangitis. And then renal bile, we can have renal bile cast nephropathy when we have deposition of this bile into the kidneys. So we have some epidemiology and risk factors. So most commonly, stones are coming with increased age, mostly in females and in people who have hemolytic diseases like sickle cell. Then pancreatic sick air is going to be associated with people who smoke, people with a history of pancreatitis, people with obesity, and people with a BRCA2 gene. And sometimes when you have the Lynch syndrome, and I covered the Lynch syndrome in my video about colorectal carcinomas, you can please check that out if you haven't. Then we have cholangiocarcinoma. It is common in people with primary sclerosing cholangitis. It is common in liver flux and hepatoliphasis. And most times they say primary sclerosing cholangitis is a pre-malignant lesion to cholangiocarcinoma. Then we have primary biliary cirrhosis, and this one is common in middle-aged women, and it's thought to be associated with people having it's associated to be an autoimmune disease. Then primary sclerosing cholangitis is found in young males mostly, and 2/3 of people with primary sclerosing cholangitis are found to have ulcerative colitis. So when you look at the clinical features, mostly we are going to have jaundice, dark urine, pale stool, pruritus, steatorrhea, fatigue, and xanthomas. And then the xanthomas are going to come because of hypercholesteremia, because along with bile acid, cholesterol is excreted, and now we are not excreting it, so it's going to accumulate, and then we have the xanthomas appearing in the skin. And the pain patterns, we can have a colicky right upper quadrant pain that is due to stones. We can have an epigastric or back pain that is due to pancreatic cancer. Then we can have a painless jaundice most of the times when we have a malignancy. And the signs, sometimes we can see the Courvoisier sign where we have a painless jaundice, palpable gallbladder. Then we can have cholangitis also due to that obstructive jaundice, where we can have the Charcot triad and the Rains pattern, and these are very high reports. So the Charcot triad we're going to have fever, right upper quadrant pain, and jaundice, and most of the times you need to do an urgent ERCP. And then the Raynaud's pentad is when we have the Charcot triad, that is fever, right upper quadrant pain, jaundice, and on top of that we have altered mental status and shock, and this shows that we have a more severe sepsis going on. And then the systemic symptoms, sometimes we can have weight loss, because you can know someone with a malignancy, cachexia malignancy, we can have vitamin deficiencies. So when we do the investigations, the labs, the most important thing is the cholestatic pattern. In fact, when you do the liver function test, you find the ALP is increased. ALP is going to be increased as well as the GGT. And whenever we have ALP and GGT increase, most of the time we start thinking this is gallbladder disease. And then the direct bilirubin or the conjugated bilirubin is also going to be increased. And sometimes when you look at the liver enzymes, the AST and the ALT, they may increase a little bit. But the prothrombin time is going to increase. And most of the time we correct this with vitamin K. And we can also check for autoimmune anchors for these autoimmune conditions we looked at, like biliary cirrhosis. We can do the tumor markers like CA1, CA19-9, which is a one for the pancreas. And how I remember this is that when you look at the 9, it has a head, it has a tail. What does that in the body? That's the pancreas. When you have carcinogenic antigen, which stands for very many cancers, we have colon cancer, lung cancer, and breast cancer, and so on. And then we can see sometimes in malignancy we have a low HB, and then we have a rare urobidinogen in urine. Then when you do imaging, ultrasound is the first line imaging of investigation. In investigations, it's the first line, and we may see a duct dilatation. See the duct dilatation or the CBD more than 6 to 8 millimeters, then most probably you're having a stone or a mass. We can do MRCP, we can do the CT, or you can say a pancreatic mass or a double duct sign. This is when you have a pancreatic duct that is dilated as well as the cystic duct, or as well as the common bile duct. That is called the double duct sign. Then we can do endoscopic ultrasound, where we can see the small stones and tumors. We can do ERCP, and this one is both diagnostic and therapeutic because we can see the thing, we can see the stones, or if possible, we can do the intervention immediately. And sometimes we do extraction of the stone with a basket. We can crush the large stone with a lithotripter. We can do sphincterectomy of the sphincter of Oddi to allow now things to pass through. Then we can do the PTC when you have eye strictures, or the endoscopic retrograde current petrography failure. So the management preoperatively, we want to hydrate them, electrolytes, vitamin K to correct prothrombin time. We want to give supplementation of DEC vitamins. These are fat soluble vitamins A, D, E, K, and give broad spectrum antibiotics. And for the pruritus, we can give cholestyramine. Sometimes we go to rifampicin, which is a P450, which has effects on the P450 enzymes, which will reduce the formation of the bile salts. Then naltrexone is also thought to have some importance because the issues are thought of to be associated with the opioid receptors. And then we can do some specific interventions. Now, if you have cholelithiasis, you want to manage that, which can be involving unusual B, ERCP, you can do sphincterectomy, extraction. If it's cholangitis, you want to give IV antibiotics. Then ERCP, which could be also retreatment. Pancreatic cancer, we may do the stage it with the CT. Then we can do repose if it's resectable. We can use a stent. We can do FOLFIRINOX. This is the anti-cancer drug. Chemotherapy. Then we can, if it's a cholangiocarcinoma, we can also intervene with surgery if it's a benign stricture. So most of this management is going to include surgery. Then the complications of this obstructive jaundice, we have been looking at them, but let's look at them once more. So we have ascending cholangitis, secondary biliary cirrhosis, vitamin K deficiency, osteoporosis due to vitamin D deficiency. Remember, vitamin D is fat soluble. You don't have fats being absorbed, vitamin D goes. Bionephropathy, we can have malnutrition or recurrent cholangitis, and the risk of cholangiocarcinoma. So the high yield tips to look at is that whenever I have primary sclerosing cholangitis, there's a high risk of developing cholangiocarcinoma. When you see a double duct sign, most likely you're having pancreatic head cancer. If the CBD is greater than 8 to 10 millimeters, then we obviously have obstruction. Then red flags, when you have a palpable gallbladder and Okuva's sign, it is malignant until proven otherwise. Fever plus jaundice plus water copper quadrant pain, that's a charcoal triad, acute cholangitis. When you add hypertension and altered mental status, that is Raynaud's. When you have weight loss, think malignancy, chronic obstruction. When you have Trousseau's sign, that is migratory thrombophlebitis, think pancreatic cancer, because of that. So we have come to the end of this video, and I hope you learned a lot about obstructive jaundice. Let's meet again in the next video. My name is Benjamin. Have a nice day. Don't forget to like the video, subscribe, and leave a comment.